Welcome back and thank you for staying with KTN Prime. Now we want to dive into a conversation, and as I had mentioned earlier, we're joined by Dr. Davji Atela, who is the Secretary General, Kenya Medical Practitioners, Pharmacists and Dentist Union, also known as KMPDU. Karibu sana, Daktari.
Thank you so much.
All right, so a lot has been happening in the health sector in general, but let's start with what happened yesterday. Doctors under KMPDU joined their counterparts in solidarity of the Kiambu doctors who have been striking for, now it's 138 or 139?
40 days.
40 days,
yeah.
Okay. One of the longest strikes we've seen. Yeah. So before we even get to what happened yesterday, let's talk about what happened today.
Yeah.
You petitioned the National Assembly.
Yeah.
Why?
Most of the times we have always been ignoring the leaders that have been elected. Members of parliament have constituents. So when you go to every county, we have the constituents who elected members of assembly in each and every county. When you talk about budgets that goes to the county, it comes from the National Assembly. The budget for the counties, then to the Senate, it goes down here. So when we're having a problem like the existence of a strike for over 39 days, over 140 days, that is the 5th month.
Yeah.
When it is reported that we're losing mothers, we're losing children because there's a political gimmicks and PR from the county, then we have to use all the available mechanisms to resolve this matter. We've gone to the county assembly. We are collecting signatures together with the residents of Kiambu to take to the parliament to actually impeach, to remove the governor from office, even to ask for that particular county to be dissolved. We have done demonstrations. We are in court. The court today told the county government of Kiambu that when you are engaging in an industrial dispute, you must do it in goodwill, not ill will. So at this time of this matter, we have to take it to parliament so that they can also get seize of this problem. Because when Kenyans are dying and we have elected leaders, it's not the right thing.
Yeah.
So we petitioned the health committee to also ask this county, what is the problem? Why can this matter be solved? Because these are Kenyans. Why is budget being done over these matters, but then the issues that are affecting Kenyans can't be sorted? So it's a reality. That's why we took it to assembly. We are doing the same to Senate.
Yeah.
And we are trying all mechanisms that will ensure that there's dignity to the patients of Kiambu County and to the doctors that are on strike in Kiambu, so that this matter can be resolved.
Yeah.
Because we realize that it seems it has gone beyond dialogue, because what we are experiencing is what we call an illegal lockout from the county, where the county does not want to engage, and if they engage in bad faith, not to solve the problem, but to politicize it.
Okay, it's a good thing you say, you're asking yourself, what is the problem? Because I believe there have been 7 conciliation meetings overseen by the Ministry of Labour Conciliator and multiple court directions from Justice Radido, Justice Ongoya, I believe. What came out of those meetings?
We've had a total of 12 meetings
12 actually.
with the county government of Kiambu.
Yeah.
We went on strike last year. The essence of the strike for last year was to have the issues of doctors resolved. That doctors need to get medical cover like every other person, because doctors have been offering services they can't themselves afford. We have doctors in Kiambu that every month we have to do collections around base for them to access care, because county has delayed in remitting the social health authority. County does not have a medical insurance. That was one of the reasons we went on strike. We went on strike because we agreed last year that there should be promotion for doctors, because doctors have stagnated over a period of time. You are a specialist, you are a consultant. You're posted as a consultant in a facility, but your payment is as an intern. We say this has to stop, this has to end. Salary delays. Kiambu County is one of the notorious counties in the country that doctors will go up to 3-4 months without the salaries being paid. And those are things that we put down into the agreement for last year in a return to work formula, which was adopted in court on 8th of May 2024. Come July, salary delayed for doctors, for workers in Kiambu. Come August, the salary of August was paid on 23rd of October last year. And so you are like, we had agreement. Why has this thing not been complied to? That everything we agreed, other counties are implementing. Ministry of Health is implementing. Why is county not implementing? That's when we went to Ministry of Labour for dispute. Kiambu County did not turn up for these meetings. And when they turn up, they sent for some junior officers who could not make any decision. The conciliator told us, go to court. That's last year. We went to court. And the court process, before Judge Wasilwa said, no, you are wronging the doctors. These agreements were done and Kiambu County ought to comply. They did not comply. The Kiambu stopped remitting deductions, including even the union dues, including sector deductions. Doctors who have loans are much more in CRB, receiving messages from CRB than anything else. So we realized there was need to take action. We therefore, when conciliation failed, we gave a notice on 5th of May, up to 26th, when the strike was commencing. There was no single meeting called by the county because it was they had a negative attitude or ill will to resolve the matters. When strike commenced, that's the day they rushed to court before Adido and said, we want the strike to be suspended. Having known the history of counties' impunity and injustice and the frustration of the doctors, the court gave the green light for us to proceed on strike.
Yeah.
And ordered for conciliation of these particular issues. We had about 7 meetings with the county based on the court order, and none of these meetings was any progressive. We agreed. They gave us promise that they'll sort this matter, but they're not having any commitment on them, and that's why we could not agree. We proceeded on contempt because these issues we're asking are normal things. Getting a medical insurance, this thing of being paid your salary, which we litigated. Then we took them to contempt. When we took them to contempt, the judge, Byram, ordered that we sit with the county and resolve the matter. Because they were being jailed, the county secretary came out to meet with us, with the whole team, and I went to Kiambu County to have this meeting. We met until, I think, 2 meetings, and agreed on issues. Then the county said they can't pay salaries. We went on strike because salaries were not being paid. And again, now we are here, they're saying they can't pay salaries. We are here again, they're saying they can't have the clause of non-victimization. Then we realized they were only trying to expunge the contempt, not to resolve the matters. And therefore, that's why the contempt is proceeding. We are expecting them to be jailed on 22nd of this month. That's why this matter did not end. And now they came out to politicize it, saying that the issues we are advocating for are not things that can be implemented, that we are in politics. But the reality is that the things that are affecting doctors are things that other counties have implemented. Okay. And that's why strike is on. Let's
take the viewers down memory lane. You look at issues such as salary delays, breach of return to work formulas. These are some things that we experience year in, year out. What could be the problem, really? You said some counties, Kiambu is part of those counties, but let's not forget, even the national government at times is in breach of such agreements. What really is the issue?
You know, the issue here is more of leadership and governance within the counties. I keep saying that you may have a very good minister, the Ministry of Health, but when you have 47 governors, where 20 of them are mad people, it becomes very difficult to resolve the matters. We have had experience like this before. When we had the governor of Laikipia and Dr. Mureithi, where the issues pertaining to collective bargaining agreement made him to fire doctors. And this was politicized, almost in a similar manner as what's happening in Kiambu. And that governor went home. The same thing happened in Kirinyaga. And I can tell you that up to now in the Court of Appeal, where county had to deposit millions to actually have the matter be stayed in the Court of Appeal, and we're still following it up. So essentially, the lockout we are experiencing in Kiambu is what we have experienced with governors who are not open to resolve problems. And that makes us realize that when we have 47 governors who are not honest to resolve the matters of workers, then we end up having lockouts, we end up having issues being politicized that otherwise would be implemented. We have seen delay of salaries even in Nairobi County. We go meet, you create alarm of it, the governor looks for ways to resolve the matter, paying salaries. We have seen the issues in Mombasa. We have had these issues in different counties. But most counties, when you create concerns, when you say we have a return to work formula that was ordered by the court, counties, you give notice, they sit down, discuss, dialogue, and implement. But that's not the case of the Kiambu County.
Okay. So there are those who are asking, okay, here we are, you've gone to the National Assembly and you're hoping for results. What is your end game? And because why they're asking this is because many say health is devolved.
You know, I keep saying this, that it is we as a union, governors also have a union, the Council of Governors. And you heard them talking the other day saying that what we are saying is false and it is politicized, that there are no deaths that occurred in Kiambu County.
Are they?
I can tell you that we have files of each and every baby that lost his or her life in that particular hospital. And the files have the names of the guardian, the parents, and their contacts.
How many are they so far?
So we had 58, 136, 58 from Kiambu level 5, and 58 from 68 from Thika level 5. And this, we don't just have the numbers, we have each files of these patients. So when the governors came out to say this is politics, they realized that there's an aspect of complacency from the Council of Governors where they are running away to hide from the truth to support one of them because they are like a union, rather than coming out to actually solve the real problem that exists. So that's one of the things that was coming out. And why was that coming out? Because when we went on strike, the county did not focus on how to resolve these matters that they have been ignoring for over a year. Instead, they went and employed about 50 doctors. And these doctors, because they're junior doctors, wrote letters complaining that we have complications that we cannot manage. We need consultants to handle these matters. They wrote to the chief officer. They wrote to the union. They say we have to refer. But then the manager say that you can't refer. So in that aspect of doing PR, with healthcare you can't do that, because when a baby or a neonate needs care of a specialist, it needs that care. When a patient needs an ICU, they need ICU. When they need oxygen, when they need proper treatment, they need it. And if they don't get it, what the outcome is, the patient will lose their lives. And that's something you can't hide. And that's why you saw even the Ministry of Health saying, we have the data of fatalities that occur in Kiambu over this period. Because you cannot hide somebody who has died. They have families. They are mothers. There is expectation. So that's why I keep saying the county and the CUG are playing unnecessary politics instead of coming down to resolve the actual issues that are not unique to Kiambu. That are things that we sat down after a 56-day strike and agreed, the things that are adopted in court. And therefore, our end game is to, one, these matters must be resolved. There's no way we can follow up something over 1 year, go on strike, and then resume duty where those matters are not resolved. We cannot allow that, because then that will be an outright enslavement of doctors by themselves in the county. Because if all this time they have not implemented, when you go back to work, they won't implement. That's one. Number two, if the issue we were fighting for is salary that was not paid for 3 months. We've been on strike for like 4 months. When all these salaries are not paid, and then somebody asks you to go back to work, is somebody who is practicing impunity. That is an injustice, because you need your wages, need your salaries to go to work. When a county that has been haphazardly transferring doctors and victimizing them at duty with their chief officer comes out and tells you that we don't want a clause of non-victimization, that is a clear expression of ill will, that they don't care whether every resident of Kiambu doesn't get care. They don't care whether these deaths continue, because to them it is politics. And this is the biggest problem we have with counties. Most governors will have an empty shell of an hospital as long as the semblance of services in the front, in the front line. Those are the issues that we deal with in the counties, and that's the problem that we face.
All right, because you've mentioned the Council of Governors. I believe yesterday they were to have a meeting with some of the Kiambu County government officials. Are you privy to what happened during the meeting? You know, that was an internal government meeting where the Council of Governors called the Kiambu to understand the impasse that exists. And I'm sure that they were explained to on the sides of the county government. It is today evening that I've had a call with the chairman of the Council of Governors, and we agreed to have a meeting on 9th, on Friday this week, around 9 a.m. to discuss these matters. Because for us, and we have put it out very clearly, that we cannot allow the violation of the rights of doctors that happened in Laikipia for 40 months and that still happened in Kirinyaga to happen in any other county. As a union, when things escalate, we have to get mechanisms to ensure that we unite. Because it is very clear that in this injustice, the Council of Governors took a stand. This injustice, the governor has decided to politicize this matter. And you see, when you say this thing is political rhetoric or it's politics, I believe the governors have the license to do criminals or criminology in politics. Okay, but when you say you're collecting signatures to impeach or dissolve the county, aren't you politicizing the matter as well? But the reality is that the power comes from the people. And the people are suffering. Yesterday we called for demonstrations. It was not a demonstration for only doctors. The public that actually bear the brunt of their children dying, that actually have to go deep into their pocket to get the health care, played a big role in that demonstration.
and they were in a big numbers. We have a planned demonstration next week again, and I believe that the members of the public will be more. And I believe also these members of parliament, the MCAs that feel this matter need to be resolved, should be also part of this particular demonstration. Why?
Next week when?
Next week Monday.
Is it on a holiday? Is it nationwide?
Oh, if it's only Monday, then we'll do it on Tuesday.
Okay. Is it a nationwide strike?
The demonstration will be in Kiambu County.
Okay.
In the same path that we followed yesterday. As I told you that we can't allow what happened in Laikipia and Kirinyaga to happen to any doctor, it means that an injury to a doctor in Laikipia is not in any way different than injury of a doctor will happen in Kisumu, neither to Mombasa, neither to Mandera or to Wajir. Because if one governor is ardent to perpetrate impunity, we know that it is the same energy that other governors will pick up. And therefore, we have a National Advisory Council meeting coming up on 24th. We have two agendas to discuss. The main agenda is a national strike. National strike to ensure that, because we have one country, we have one treasury, we have one president, we have one Ministry of Health, and therefore one governor cannot hold all of us on hostage. So we will take action that unites doctors across the country to ensure that actually this governor gives into the issues of the doctors. That's one thing. Yeah. The second thing is that we had agreements over the adjustment of the basic salary for doctors, which has not been done for 7 years. The Ministry of Health and National Government and Treasury have paid their arrears. And that's one thing when we talk about this minister, on Dwale. The fundamental thing he has done, that the agreement we had, the return to work formula, he has implemented part of the ministry, a part of the national government. But the county part of adjustment of salaries have not been done up to now. So when we are giving this notice next week, it will be on those two matters. And also the issue of medical insurance, that most counties have decided to go into tenderpreneurs and into kickbacks rather than actually offering the medical insurance. Okay. So those are the things that, so I can tell you that as much as we're collecting signatures, as much as we are petitioning the parliament, as much as we have petitioned, we're trying to have this county dissolved, we're also going to take a national action as doctors of Kenya over this matter. Because if it is left unchallenged, then we are going to have a bad precedent and a bad situation that we already experienced before when we left counties to work in a fragmented way.
Okay. Before we even put this matter to rest and move on to other issues, I would love to know, what is the status of healthcare facilities in the county? Because we have had reports from various counties where they don't have bed capacity, medicine, and all that. What is the state?
I will start particularly with this Kiambu County, where we have had a lot of politics and a lot of alterations that healthcare is functioning. Yesterday, we had a call from one of the clinical officers working at Thika Level 5. And he told us that the level of fatalities that he's seeing, the way they're being told to manage the patient they can't manage, is quite unethical. The data that we have from Kiambu County, where we have the neonates that have been dying, where we have mothers that have been losing their lives, where we've been losing all these situations, are not reported by strangers. They're reported by these new doctors that they employed. Because a doctor that is employed in an hospital, his major role is to ensure that a patient is treated and a patient is discharged. That when you lose a patient, knowing very well that there are no drugs, there are no equipments, and most worst situation is that the county has sent away consultants that you can't, and the complication you can't handle, and there's order given to you that you can't refer, which is part of management, then you lose this patient, you lose part of you. So these doctors have come out swearing that, yes, they want to keep these new jobs that they have gotten because they were unemployed, but the situation down in that county is unbearable. I've seen today some religious leaders coming out to say that the situation is okay. But I can tell you, those leaders don't get health care in those particular counties. They have private premium insurances that they will go to big private hospitals. But if you challenge them, go to the hospital and find a doctor, get treated, get the surgeries, get the procedures, they will not. So the reality of Kiambu County is that we need honesty. And it's just a matter of court process. Otherwise, we'll have asked the doctors who are offering minimal services to leave the hospital. But it is not our pride as a union that the patients who need emergency care, the patients who need to be referred, to be stranded. That's why we left minimal service in the county. But that should not be misconstrued to be a full function of the county. Okay.
What are your irreducible minimums as a union, especially with Kiambu doctors, so to end this standoff? They need to, is there anywhere we can meet halfway perhaps?
we have already gone past halfway. We have given county over 3/4 of the issues that we demand. Because, as I told you, we took them to contempt.
Yeah.
They draft a concept that they're going to resolve this problem. Like promotions, they say they'll do in 2 months. They say that in 60 days, they'll be paying the medical insurance on time. They say that they're going to start remitting certain deductions. They say that the arrears for loans that they have not paid, they'll start paying and they'll be up to date. That means they have not done. They say they will do. And that is an aspect that the union has already compromised over the matters. But then they're saying the money that has been budgeted for doctors, that the county itself has been giving the control of budget to be paid. They say they want to pay this money. They say they don't want non-victimization clause on this matter. You get? That tells you that they're operating on ill will, that they're planning to actually victimize the doctors. Because they've been doing that. It means they're planning to eat the money. I think that the right word is to eat the money meant for doctors to go to work. So as much as we've compromised 70% or 80%, we cannot have an engagement or a discussion on somebody who is robbing your salary when they already robbed you the rights of you to be at workplace. So we have compromised already. So it's upon the county to release the money meant for doctors to be facilitated to go to work. And if they do that today, we will go to work. Doctors will go to work.
Okay.
If they do it on Friday when we meet with the Council of Governors and the Kiambu County, doctors will proceed to work. But any attempt to rob doctors that money, any attempt to act to victimize doctors when they're exercising their constitutional right, that cannot be taken by the union.
Okay.
Yeah.
Let's wait and see. Hopefully things get better. On Friday, you'll be able to solve the situation. But if not, we'll be here having this same conversation next week or next week but one. All right, I want us to talk about something else. Today, the National Assembly's Departmental Committee on Health had deliberations with the Ministry of Health and other stakeholders on the committee's recommendations arising from an assessment of SHA's utilization of funds since inception and the challenges faced by health facilities. And tempers flared, and that's the story we're leading in at the Standard tomorrow. But let's listen into what exactly happened.
Produce evidence that you are the one who should not in this ministry. Your company is stealing from SHA.
He keeps taking swipes on the members of this house. Honorable he needs to make a decision whether he wants to come back to this house or serve this nation as an executive member.
She's a junior member, down to a ranking member.
Whether fast or fit, it does not matter. I am here legitimately and he cannot continue taking.
We are not your kids here to come and unatusomea kama watoto wako.
My kids are not.
This is a committee and we will not. You are a hostile witness.
You and your friends are stealing from SHA. We have closed your office. Where? I don't know a hospital. And if possible, we will charge you in a court of law. Who has extorted you? We have closed your hospital. Who has extorted you?
It is not in your place on how this meeting is conducted.
Right. What is your reaction to what happened today? Let's start with that.
You know, the alteration that took place in Parliament today is a little bit unfortunate. But you see, the reality, it was taking place between politicians. The CS Health, the CS Treasury, the CS Energy, and even the CS, the former governor of Mombasa, and even the one for investment, they're politicians. And one fundamental thing that always happens in Parliament is that when you are summoned and you are not a politician, they will sometimes rain down on you, and they can make you not feel, not represent what you want to represent.
Yeah.
Like, for example, what occurred here, that the questions for the minister, I believe, were shared before, and what was happening is that they were asking questions that were not part of it. So he said, give me 6 days to have these matters presented, to give the report for them. And I think that's when the MPs brought that other aspect of politics. But as I said, as these ministers are politicians, they have to respond politically. That's different when a technical person goes, a different technical person goes there is not a politician. And there's no way I would at any point support parliamentarians over this issue of social health authority. Because in 2023, when this SHA was being enacted, we took submissions to Parliament. We went to court over these particular matters. And the parliamentarians, who have not changed, passed it without change of comma or full stop. You know, you cannot come 2 years later when somebody, a minister who was not there when you are actually passing this bill, is trying to implement it, and they start shouting. So I believe that in the parliamentarians got a response from a former parliamentarian who's a politician. So it's more of a political engagement on this particular matter.
All right. So what's your assessment? Down the line, 1 year down the line.
My assessment is that there are bigger challenges in SHA in 2023. And one of the things was the non-involvement of the stakeholders in it. But there has been improvement. And I'll say this without any political inclination and with reality, that first of all, before the minister, Duale, came on board, we had an issue of ICU, which was rebutting or having 4,000 per night. Now it is 28,000. That's what they rebut every night for a patient. We had an issue of the oncology or oncology, which was at about 300,000. When it came in the first 2 weeks, that was changed to about 550,000. The real issue of social health authority is that the parliamentarians ought to budget more money for it. Because the crisis that is existing now is that if you look at what the Rufa and the team have been saying, is that the money that is being approved every month is about 9.5 billion. The money that is being collected every month, they're saying, is about 6.5 billion. That means there's a lot of people that social health authority is approving for this particular to cover. And now the crisis that exists is that the debt that is there is about, as they say, about 20 billion, which means the people who have gotten this care to have debts for debts to exist are Kenyans. And one manifestation why these debts are a lot like this is also the dysfunctionality in public hospitals in the counties. Because if public hospitals were functioning on a different side, I don't think lots of money would be accrued in the private facilities. So the solution in this issue is the health committee need to look at how much do we need to adjust in the primary health care so that these things are paid. We should also look at how do we ensure that more Kenyans are actually enrolled and paying in this social health authority, because I can assure you that healthcare cannot be free. Healthcare is two ways. Either government or tax pays for this particular healthcare, or people contribute out of pocket. So the essence is that the parliamentarian, the health committee, the parliament need to look at how much they need to add, and then we need to have there's a mechanism on how many people can be on board and then subscribe and pay for it. So I would say that from last year to now, there has been improvements. And the issue of it working is not a matter of question. Because we have seen, they say that that's 1 year there's been 90 billion that have been approved. So it means that this is approved because people have gotten the services. The issue is the debt payment.
And we'll get to the debt payment, but let's talk about what this committee found out after they did, I guess, a status check. A visit to 10 hospitals revealed that a series of systemic challenges transcend policy challenges. So it's a matter of the system. Talk to us about that, because you interact with it, I believe, more than we do.
So now we have to look at the systemic challenges in the system that was procured, or systemic challenges in access of care in the hospitals. That's what you have to look at strongly. Because we've had the system problems of insurance, both in NHIF and in Social Health Authority now. And that's why we saw last year, during last year, when they were trying 2023, the former Minister of Health kept on saying there's a lot of frauds and fraudulence in NHIF, and a lot of money is pilfered out through that process. And that's why they say that they bring up this system of social health authority to curb that. Which
they didn't, because clearly just the other day we saw the CS at Duale say there's fraud.
So that's now the difference. So that was the main thing. So the system challenge that I think will come about is the aspect of the existing fraud, which happens both with the internal persons in this authority and the practitioners and the facilities. So ideally, it requires an aggressive action. Because the moment you have said there's fraud and you have the list of the people that are having this fraud, it means that the stand is different from the point when we used to say there's fraud and there are no people that are being prosecuted for that. The thing that I will say is that when there is a suspected aspect, SHA need to fast track this aspect of tribunal and resolving those matters. But ideally, I believe that the challenges that exist in the system, the challenges that exist in policies, are a matter of conversations and a matter of the act being passed. And that's why there has to be, I would say, deliberate, objective discussion between the Ministry of Health, Social Health Authority, and stakeholders to resolve this.
You think there's goodwill?
I saw what the surgical societies did regarding this issue of geomapping of practitioners. They went to social authority to bring, because there's one side that that SHA trying to say that if you are a consultant, you need to be at a particular hospital at a particular time. But then they're saying, no, you can be home, but then admit and go do the procedure. Or you can be in one hospital and then go do that place. So there's a point of doctors that is very clear, which then contradict what social authority was bringing up. So bring this team on board to discuss and make it win-win for the doctors, win-win for the patient, and win-win for SHA is what is more critical. It's not a political conversation where every other aspect of authority is said to be bad. Yeah.
Okay.
So the goodwill that you're asking about, I find more goodwill now with the on CS Duale compared to the one that was there before. And you see, this social authority, we have the CS Duale, and we have Dr. Omoluga, who is now the PS for health. And Omoluga has understanding of the issues that were there for workers, the issues that are there for the Kenyans, and the issue of trust for public health care. And now is the PS for medical services that SHA is under. So I believe there's, and when you look at SHA before, the leadership of it, there was no, we have Dr. Mwangangi here, we have the benefit package, we have Professor Jaokum, and then we have a claim where, the claim management where we now have many doctors on it. I believe the aspect of bringing practitioners on board, the aspect of open dialogue for issues that come in, devoid of politics,
is a step
it's a step in the right direction.
Okay.
And the other matter that is very key in social health authority is, whether it's to what extent having the insurance or social insurance for the people is good. That's the first step. Because if you don't have any insurance, you can't access the care. It means you have to pay out of pocket. So the first thing, you must have a particular social health insurance, because at one point, NHIF does not exist anymore. So those are the balances that we have to look at and then see how do we increase the benefit package for the Kenyans. And the fundamental aspect of that is how do Parliament increase money? How do we get the over 26 million that are registered to now start contributing? That's what will bring the change that we need.
Okay, so when we look at this SHA, it was supposed to, bring about quality health care, affordable and accessible. Do you feel like it's intending what it was meant to, even as we think about universal health coverage?
The intention of social health authority or the intention of universal health care is that every Kenyan must have the ability to access health care, devoid of socioeconomic status. That means if you are sick, you go to the hospital, you get your care, and you go home. One thing that SHA tried that was a problem in NHIF is whereby when you register, you don't have to wait for 6 months to get the care. You register, and with the shift you can get the care, or with the primary health care you can access the facilities. The only point is whether it's on the payment aspect, but that's the fundamental that is there on it, which is different with what was there with NHIF. So ideally, the intention of Statutory Health Authority, the intention of UHC is to ensure that Kenyans can access care. The need which is there now is that more money needs to be there so that the agreed timeline of payment of debts, 30 days or 90 days, is paid. Because if that is done, and that can only be done, and it can only go smoothly when you have functional public hospitals. Because when you have functional, well-equipped, more doctors and health workers employed in these public facilities, then even the burden of service provision by private facilities will reduce. So it means that the money aspect needed will not be the same. But that's not the case right now, because the reality is that the public facilities are not functional in many counties, and therefore there is a bit of a reliance on the private facilities. So there is need to have more money in the Social Health Authority. Okay. And therefore there's need to move that conversation.
Other things that they came across during that assessment of theirs is the issue of unpaid claims, which has been one of contention for quite some time now. But let's just be fair that I think it was last month, Health CS Duale announced that the government will clear all pending bills amounting to 5.3 billion shillings in the next 2 months. So let's wait and see if by November that will be the case. But they say that there is lack of clear redress when it comes to claims, transparency. Do you believe that's the case?
You know, I believe that whenever there are issues that are addressed in terms of transparency, it's a two-way thing. Because if you compare NHIF rebates or payments and social authority, there's difference. The difference is the Ministry of Health and SHA are now publishing the payments they're doing on the website. And you can know which hospitals are paid how much, which was not there before. So the politics or the criticism on the transparency is based on the payments that have been done. That's one thing that was not there before. And that's an aspect of transparency. The only thing that I think hospitals have been talking about is that when they are paid, they don't know which of the claims that they have claimed that has been paid and which one is pending. And that sometimes make them, you may get 50 million and owed 100 million. So you don't know how much, which particular claims are pending. But the aspect of transparency in terms of what has been paid to particular hospitals has been public, which was not there before. Okay. So I believe that, and I keep on saying, because this was a new act. You know, NHIF was 60 years old. It was started in 1966. SHA is just 1 year old. Yes, it's here with us. What would be the best way to do the things? We have to reduce the politics and look at how do social authority work for the Kenyans better? How does it work for the doctors better? How does it work for healthcare workers better? Because with that, then it's much easier to enhance this thing, to enhance the social authority as expected. But when we always run on the political side, then even the good things will be politicized. As I've told you, that many of the politicians, many of the people that actually say this thing, the SHA is not working and things are not moving, when they have the house girls are sick, you will see them paying for the house girls and they go to the hospital and seek care. The people who actually say it works, but the people who also gain in the political discussions. So there's a balance here. So what it then needs, it needs an objective responsibility of the stakeholders to actually give inputs that improve it. Because when we politicize it, the way we are doing, it's up to when? And will that give us the outcomes that we need? The parliamentarians, they pass the act. What they need to do? They need to increase the money. And when that is done, I can assure you, the money is increased to the Ministry of Health, to SHA. When there's increased contribution and payments are done, I believe that there will be a different conversation. Okay. Because to me, the crisis that exists, where Kenyans have accessed care and government holds the hospital, is a better crisis than when you go to the hospitals and you denied the care.
Okay. Yes. You're looking at the glass half full instead of half empty, yes, which is a good thing. Okay, let's talk about this SHA, because it was supposed to be a cornerstone of universal health coverage. From where you sit, in this journey of ours towards UHC and with SHA involved now, where do you think we are at? And do you think we'll attain our target?
I think we have to be cognizant that the cornerstone of healthcare is the financial aspect of it. That we can have a dream to have a universal healthcare that is accessible to everybody, but there has to be money for it. There's to be money that if people go to the hospitals, they actually get this care that they need. There has to be money to employ doctors and healthcare workers in the hospitals across the country. Yeah. There has to be drugs in those particular hospitals that if you go to level 2, level 3, level 4, that is said to be free, you actually get the care, you get the drugs that you need. That is what is called the universal healthcare. That there are equipment that if you go to the hospitals, you are not again sent to go outside to actually get diagnostics. You can do it there. And I've seen this NESP program that has been started by government. In one way, people are saying it's privatization. Yeah. But on the flip side, you look at it, what value does it give to the patient? At that point, because you go to the hospital, and for a long time you're in Wajir, where you go to the hospital, and when you're in the hospital, there are no equipments. But now the equipments have been brought. You go to Kisumu, you go to any other county. These equipments were not there before, but now the equipments are there. And you're being told that because there's a contribution in Social Health Authority, you will just be diagnosed to get the care and go home. So it makes its balance. Is it then, who benefits in that process? It is the patient who gets the care. Because for doctors working in public facilities, your responsibility is to ensure that the lab requests are actually done. Your responsibility is to ensure that the drugs are there for the patients.
Okay.
Your responsibility is that a procedure you're going to do is done in the right way. You get? So the administrative aspects of the equipment, the drugs, all these things are part of the government ensuring that you're supported to give the care.
All right, finally, as we wind up, if you look at what leaders are saying when it comes to matters health, even when they go to, the outskirts, mashinani, the rural areas, their clarion call is we need to embrace preventative instead of curative healthcare. For our viewers who are not perhaps privy as to why this is important, break it down as we wind up.
They say that preventive, when you look at the aspect of preventive, it means that there's enough screening, there's enough, there's the social aspect of health, so that you actually prevent the disease in itself. So that means there's aspect of hygiene in the villages, the aspect of vaccination. So that is the major aspect of prevention. Because most of the time, when all this is done, the screenings are done, the vaccinations are done, and there's hygiene, and there's clean water, there's food, all these social determinants of health are considered within the primary setting, then there's always higher chances of reducing the curative aspect of people going to the hospital, the number of treatments and all that. You remember during the COVID-19, when all those safety measures were being practiced, you realize that some of the conditions were actually being prevented. That is what we mean by this preventive aspect. So there's and that's what I think was being envisioned by this universal healthcare. That there's need to promote preventive measures within the communities. But that doesn't mean that we need to have only community health promoters. They are good, the community health promoters, in the sense that they sensitize the community on the aspects of the hygiene, the aspect of healthcare, on why you need to go to the hospital, why you need to have early interventions. That's the aspect of the community health promoters. But we know that there's need to have doctors within the community setups. As part of this particular aspect, the family physicians, the doctors, the healthcare workers, because then that enhances the early detections of diseases. So that is a very key aspect of it. And that's why one thing we've been discussing strongly with the new minister on the promise that was given in the return to work formula, the employment of 2,000 doctors, the Kenya Kwanza manifesto of employing 20,000 healthcare workers. We discussed this with the minister. We discussed this with the president when we went to the State House last time, with one aim, that there is don't have a possibility of realizing the universal healthcare when we don't have the healthcare workers in the counties or in the hospitals. And that brings us the need, on our call. Will we have healthcare workers in the counties when we have a devolved function where counties saying that they have exceeded the budget and they can't employ? And what mechanisms will be used for government to ring-fence funds for employing doctors the same way, and healthcare workers the same way they do for police, and the same way they do for the military, and the same way they do for the teachers? Because every year we hear all these other cadres being employed, teachers, military, and police. But we don't have a plan of employing of doctors. Even the 20,000 that was promised has not been employed. So that's one conversation that we have taken up strongly, because it was part of our return to work agreement. Lastly, I want to say that when we talk about the Minister of Health, we are coming at a point where we've had a lot of agreements being signed and not being honored. But for the first time, we have intern doctors, where we went on strike for 56 days last year. And even this year, we were planning to have, in December, we were planning to have a strike. This year, we plan to have a demonstration. But you got a minister. We sat down with him on 10th of April and discussed the collective bargaining agreement, the issues of remuneration of the interns. And he took it upon himself. He said he's going to talk with the Treasury, he's going to talk with the head of state to ensure that the collective bargaining agreements are aligned. And you can take it, it's well out here, that on 1st of July this year, for the first time, 6,000 interns were posted, being paid 208,000 as per the collective bargaining agreement. That was honored. When we have had 3 ministers we're fighting over this matter with. We have the issues of the doctors' CBA arrears that we fought for from 2017. It took our engagement with these new ministers and this government to have this paid in December and this paid in September this year. And we didn't have to go back to the streets to have that particular paid. We have issues of postgraduate. That was stopped in 2019. We have doctors, around 633, who have been going for postgraduate. They are delayed even to returning to counties. We had engagement with this minister and his team. And we have had those fees approved. Almost 420 have been paid. And there are the remaining I think 233 are being paid in this financial year. So the difference that we have as a union is that the current minister, on Dwale, in his engagement with the union is bringing the stability that we have needed for a long time in the health sector. But on the flip side, because health is devolved, we have 47 counties that the same things that we agreed and signed are not being implemented. Today, on my desk, there's a strike notice for Marsabit County. Today, we have seen doctors in Migori asking for a strike. Why? Because their salaries have not been paid. Last week, there was a demonstration in Nairobi. So it becomes very difficult when you have 47 governors, where 37 will be very okay doing things, but about 20 will not be bothered to resolve the same issues that have been brought to them. That's why we have problems.
Okay.
We've had an incident in Migori County where a governor decides to fire a doctor because he has disagreed with the wife of the doctor, because he has disagreed with the husband, who is an MCA. A doctor in Migori was fired. Why? Because the governor, Uchila Yako, has disagreed with MCA. And therefore, he employs this board. The chair of the board is being told, now fire this doctor, without any reason. So those are the things that we face in the counties.
Okay, but for our protection, we're going to treat that as hearsay, because we do not have evidence at the moment.
It's me who has said it, so I'm responsible for it.
Okay.
Yeah, because I'm not dealing with it. And that's what I'm telling you, we're going to have a strike also in Migori over these matters. So you see, so as much as we may have a good minister who does things as agreed, we will have about 20 to 30 counties that are not doing things that are agreed. And now we have 47 counties who have not implemented adjustment of salaries as we agreed. That's why in our meeting that is coming up on Friday, we are going to tell governors that as union, we take actions in unity.
Okay, yes. All right.
And we are going to have these matters implemented.
All the best, and let's see what comes out of that meeting. Thank you very much, Daktari, for your nuggets of wisdom and, of course, creating time for us here on KTN Prime. Dr. Davji Atela, Secretary General, the Kenya Medical Practitioners, Pharmacists and Dentists Union, also known as KMPDU. And that's how we wrap things up here on KTN Prime. Thank you so much for trusting us. On behalf of our stellar team, including Jesse Rogers and Marisha Wheat, and, of course, Waweri Njoroge, I'm Ashley Mazuri. Have a good night.